All right, should be recording.
All right. Well, hello. I'm Nicole Pullen. I'm Executive Director for the Family and Children's Trust, or FACT, of Virginia. And we're here today for our monthly Lunch and Learn. We're having a series on different programs in Virginia state government that are being offered to provide support around our work of preventing and treating family violence across the lifespan. And today we're joined by Lori Crawford, who is director of the new office, not that new anymore, but Office of Trauma and Resilience Policy with the Virginia Department of Social Services. And she's going to tell us a little bit about the work coming out of that office and some of the exciting new initiatives happening around the state in this field. So thanks again, Lori, for joining us. We're really
Thanks for having me.
Yeah. So tell us a little bit about your office. And as I said in the beginning, this is kind of a fairly new entity in social services in Virginia.
Yes, I'm wondering how long I can say that it's new. This office, which is a division of the Department of Social Services, which lives within our policy and administration, our portfolio, it was created in April of 2022. So it's been right about 2 years now. We brought in our first staff in June of that year. And so it was just kind of a little brief background. We had, beginning in 2015, a 6-year grant from the Department of Justice Office for Victims of Crime to better connect systems of care for children and youth who've experienced adverse childhood experiences, trauma, and just to kind of get all of the different systems, whether they be juvenile justice, education, child welfare, behavioral health, on the same page in terms of how they supported children and families and linked their own systems to each other. And so that grant was 6 years, and it was a demonstration project. So one of 4 states in the country, initially 2. And when the grant came to an end in 2020, well, it was getting ready to come to an end in 2021. Later that year, we were thankfully had a lot of support from our leadership and administration to sustain that work with general funds. And so we created this office to continue that, but also to expand beyond the work of the grant. Oh, I think you're on mute.
So sorry. So what are the focus areas of your office?
So we kind of divide up by 3 audiences, so to speak. So the first is really continuing the work of that Linking Systems of Care grant, which later became known as Virginia Heals. And I know we're going to talk about that, but that's really working with service providers across systems, folks working with children and families in community to implement trauma-informed service delivery with the folks that they serve. And so that's really the community level work. Within that umbrella falls a lot of things. Our work with the multidisciplinary trauma-informed community networks and community, and some other just work that we do with folks from all different systems well outside of DSS. The second is coordinating our state level efforts. So we have all kinds of state agencies that are working in various trauma initiatives and efforts, not just DSS. It's obviously pretty much every state agency has programs and work around trauma. And so we are trying to kind of better connect that work. And we staff our state's trauma-informed leadership team, which is representatives of about 13 different agencies doing work. And we convene to just better coordinate and collaborate around our efforts. And then finally, the really new part of this office that was not done as part of the grant was really our internal work at social services and culture change in our organization to be more trauma informed and healing centered and better support our workforce. And that is really from state and local perspective. So state VDSS employees down to local DSS employees in all the localities in Virginia. And interestingly, that piece has been really the part that's been really shown to have a strong need and has taken a front seat in the work of our office, especially over the last year, because it's just something we didn't do before and there is a need for it.
So that's great. And I have a couple of follow-up questions to that, but I want to kind of finish up the structure around the work that you do. So what kind of staff do you have and what kind of workload do they have? Because it's a
Yes,
lot on your menu. So
I know, I know.
how are you doing
Some,
that?
so we have, it's myself and then two policy specialists who are full-time positions, and an administrative staff specialist who I call our coordinator of all the things. And so we have certain things that we work on together and then certain things that we kind of have assigned leads on. So some of our big projects right now are this workforce support piece. We have been doing a lot of research over the last year, and I know we're going to be talking some more about that, but what we wanted to know was how to better support our workforce, what their needs are, particularly at the local level around and family services around vicarious, sorry, that's my dog, around vicarious trauma. And we kind of knew what we were going to find. And we'll talk more about that later, but we've been doing a lot of research to really guide a program moving forward. We also coordinate a state level group of folks who coordinate different groups of folks with lived experience. And so that's in a lot of different agencies. And I think we have about 6 groups just within DSS, and to try and really work in terms of best practice for that. And over the past year and a half, we got some ARPA dollars, the American Rescue Plan Act, state and local recovery funds. We got some funding that was appropriated by the General Assembly to support trauma-informed community networks. And for anybody who doesn't know, those are really multidisciplinary groups in community, whether they be a cluster of localities or one locality. They're all kind of different, but they have folks who come together and really try to coordinate that. They try to link their systems of care and community and do a lot of training and education. One of the big pieces that we did with that was to contract out with Greater Richmond Scan that coordinates all the different trauma-informed community networks or TICKNs in the state to develop and implement a statewide public awareness and education campaign around trauma. And so that's training modules, Resilience Week activities, different awareness materials, and that's ongoing. And then we also have Healing Centered Organizations Learning Collaborative. And so that is where we funded organizations within 5 different trauma-informed community networks to really go through a process of how they assess how trauma-informed and healing-centered their organization is, how they use that data to guide priorities and goals for becoming more healing-centered, and then for developing a plan and implementing it. And so we've been kind of in the midst of this learning from each other on that piece. And we do some limited training. We try to we're not a training group. That's not our primary function because we've got folks who do that. We have plenty of trainings. But what we learned, for example, was that at the state level, our state DSS employees, our local employees get training on trauma, but our state folks really hadn't. So we found there was a need. So we developed a course on foundational trauma and recently vicarious trauma for those folks. And then, of course, as part of that linking systems of care, work, and community, we do a lot of training at state level conferences on various parts of the trauma-informed model of service delivery and how to implement that. And I know I'm missing probably lots of things, but those are kind of the big things that we're working on.
So let me back up a little bit for a broader audience to kind of break down
Sure.
some of these concepts a little bit. So when we talk about trauma informed, what does that mean? Can you tell us kind of generally what that means and maybe give us like an example of
Mhm.
how that would be put into practice to help people really understand what we're talking about. Because that's a term I think that's used a lot without
Mhm.
a lot of
Mhm.
context. So I want to provide some context for that.
Thank you. Yes, you're right. It is definitely used a lot. I think just the term trauma is used. I'm not going to say it's overused, but I think people have learned so much that now it's kind of used as a label with anything. But trauma, really, the way we, define it is Sams's definition, which is someone's experience of harm, whether that be a physical harm that has like a lasting impact on their, whether it's their social connectedness, their, mental health. And, it's really experienced individually by different folks. So you could have two children, for example, who have the same experience of trauma, whether that, it's not always going to be things like, yes, it could be child abuse. That could be a form of trauma, but you may have them reacting very differently to it. And one has more of a long-term effect and one is more short-term. And just in terms of some of the principles of trauma-informed care, also from SAMHSA, and that's the Substance Abuse Mental Health and Services Administration. Trying to limit my acronyms too, but they're kind of they created a lot of these concepts or really put them down on paper. And they, it's things like transparency and engagement and empowerment. So to give you a solid example, and I really want to kind of relate it to the workplace because I think a lot of us can more directly connect, oh, this person experienced a sexual assault or child abuse, and we kind of can wrap our heads around that. But we don't see, so in an organizational level, it could be, are you being transparent with your staff and with your peers about what what the positives and negatives might be of a situation and giving them some kind of choice. The same is true with people working with families. A lot of it is that we have tons of things in our system that we can't fix, that are not easily fixable. And sometimes the ideal referral may not be available or may not be accessible. But are we actually having conversations with families and saying, here are the different options. Here are kind of the pros and cons of each of those options, and then letting them make the decision based on what they think is best in their scenario. So, a lot of it is just about really engaging folks in processes and collaborating with them on decisions that are made in an honest way, and then moving forward in that and really looking for their strengths instead of totally focusing on what, has happened to them.
Well, thank you for that. And I'm interested, to hear more and about kind of the workforce development within social services, because I think that, a lot of people outside of social services and outside of human services might kind of assume that people in social services are social workers and social workers already know all about this stuff, right? It's already taught to them. They're the ones that know all this stuff. And how, it's interesting that that's not always the case. And that's so it can you is this like how is being trauma informed and how is that kind of related to some of the old concepts, but also some of the new? Is there like new science that is being connected to? Can you kind of speak to that? Because I often think that sometimes there are old principles that like
Mhm.
good teachers, good social workers 50 years
Right.
ago were doing,
Mhm.
but then there's stuff that's changed and that's new. Can you talk about a little bit of that?
Well, and I guess every new is always relative, but we know we've learned, and it's still in the recent past overall, but we know that we've learned a lot about like the brain science behind trauma. And without getting too much into the details, essentially, trauma creates changes in our brains, and it can from a very, very young age. But what we've learned also is that there are ways that you can rebuild those, that you can address that, and that you can heal from it. And so we've got to really look at what are the strategies for doing that. In terms of the workforce, I would completely agree with you that There are a lot of assumptions, and I know even so for one of the deliverables or the toolkit items that we created as part of that grant, that Linking Systems of Care Virginia Hills toolkit model, which I'll share the website and all of that a little bit later. But one of the things that we thought was we had a lot of people at the table who said, you know, we created the screening tool for trauma for children and youth. And we initially thought, okay, this is a brief screening tool to identify trauma. It's not a psychological assessment. So we were like, let's have folks who are, you know, mentoring youth or Boys and Girls Club or who in these different coaches or whoever could use this. And there was really a strong feeling that we need to have people who are experienced working with children and families who already know this. And what we found when we piloted it was that there was still this huge discomfort with having discussions about trauma or traumatic incidents, even by people who have been in the field for 20 years. So a lot of times it's that not people often see or have for years now, folks are learning more. It was like trauma was, you know, what is wrong with you? You know, that was like a diagnosis of something that's wrong. And now we know from people who've been doing this work a lot longer than me, such as Bruce Perry, which I would recommend looking up for anyone on this call, that, you know, it's really more what happened to you, and kind of just that shift is a big piece of learning about trauma, because it takes us away from that, you know, kind of making that diagnosis, because it's not a clinical diagnosis to say you have this. You could have post-traumatic stress disorder that could be clinically diagnosed, but trauma itself isn't. And so because it's based on, you know, it's things that happen to you, then there are things that can also happen to you to move forward and to be able to go on to be healthy, and to cope.
Right. And hence the resilience in the name included in the name of your office. Um, what are other states doing? Are other states doing work similar to this? How does Virginia compare and vary to some of the other states? And are there particular states that, because I know you've done research on this, that
Yeah.
really kind of are ahead of the curve on this work?
So New Jersey was the first state to create a state level office, and theirs is called the Office of Resilience. And it is based out of their Department of Human Services, which is equivalent to our Department of Social Services in Virginia. And so they were one of the first, and we like to say we're the second that were in a state agency office. But there are lots of other offices, advisors that are, but they're pretty much all based out of the administration, so governor's offices, so they're appointees in many cases. And you know, there's not to say one model is better or worse than the other, but for Virginia, we really found that this would bring us some continuity over time in the work, and that it really, you know, just kind of was a good fit. I will say that we have different national groups now. There are enough of these efforts going on in different states that we have a group called Pathways to Resilience, which is state leaders that get together, and they do a lot of learning sessions. We're all kind of commonly, I think, looking at how to better or more effectively and genuinely engage people with lived experience. That's kind of a common theme across agencies. Also trying to figure out how to connect with community, and how to better coordinate across all of our state agencies and programs. So that's kind of the common things. There's another smaller group called the State Trauma and Resilience Network that's run out of the National Governors Association, which started as a learning collaborative, but we just kind of wanted to continue. So it's the six or seven states that were initially in that learning collaborative and that have continued on. And we really discuss more specific to policy. And I think that's kind of a place where Virginia So for instance, New Jersey, when they were really almost entirely in community, that's changing some now, but when they were first when that office first stood up, it was pretty much they kind of divvied up the state. And that's a great model for a lot of reasons. We really thought that because we'd done so much with the grant and okay, we've done the research, we've developed the toolkit, we've developed the trauma-informed model of service delivery, we've got e-learning. Now, what do we need to do to create policies and practices that support truly implementing that? Because as you know, we can give people all the training in the world. And if they go back to a system or policies that don't support what they do, then it's it's not very valuable. It's not, you're not really going to move forward. So in order to really move the needle, we have to, and we take a very broad definition of policy. So this is policy, meaning in at DSS, we call them guidance documents, but policy can be, what do we give out to folks in when they go to family resource centers after some sort of um, like a natural disaster in a community and you have people experiencing homelessness or a mass casualty event. They go to a family resource center and you need to give people, here's the rules for this center. What do those look like? Are those, are you coming out and saying, don't do this, don't do this, don't do this, we'll call law enforcement if you do this? Or are you saying we're here to help you? and really just sometimes it's just the language that we use with folks and starting them from a place of we are here to help and not here's all the ways that you can't get help. So it's policy in a wide range of ways and places, not just legislation or official policy.
Awesome. So tell us about Virginia Heals, the model and toolkit, and how many communities are using it. What kind of feedback? Just tell us about that.
Sure. Can I share screen now, actually?
Yep, you should be able to.
Okay, let's see. Okay, so can you see my screen?
Yep.
Okay. So this is the Virginia Hills website. So just to clarify for those who aren't familiar, the grant that was the Department of Justice Office for Victims of Crime was called Linking Systems of Care for Children and Youth State Demonstration Project. We decided to rebrand, that's not a very easy name to roll across your tongue. And so we rebranded as Virginia Heals, which is actually helping everyone access linked systems. Over the course of many years, we conducted a lot of, we developed this screening tool, which I'll, share the toolkit in just a moment, but we piloted that and did research on it with VCU for about 4 years. We did a listening tour, which is our listening sessions with children, youth, and families who had experienced systems, meaning that, they were engaged in foster care, they were involved in juvenile justice, whatever those systems, usually multiple, and talked to service providers within those systems, and learned about not only what were their experiences, but what would make it better, And so we, over the course of time and a lot of collaboration from, I should mention this grant, it was cross systems. All of these materials are made to be, you can use them whether you're in education or juvenile justice or social services or any of those systems. We really specifically wanted to make something that everybody's on the same language. So we came up with what we call the trauma-informed model of service delivery. And you will see here that it's got reviewing policies, engaging families, training staff. Those are kind of the agency and organizational level pieces. And then for direct service providers, those frontline workers, identifying services that are needed, really with a focus on community-based services, keep families out of systems as much as we can. screening for trauma, and then making referrals that are really family centered. And so we created a toolkit to support implementing this system. So we have just very briefly, because anyone can go to virginiaheals.com and download all of these, but we have a resource mapping facilitation guide, which is really for like anyone who can get folks from different systems and community together, 30 people, they can pull folks together and they can have a conversation and go through this really specific, it's like a playbook for about 3 hours to identify all services that are available in their community. There's a screening tool, which is, as I mentioned earlier, it's called the Screening for Experiences and Strengths. And that is really just a screening tool, a brief screening tool to identify what kind of experiences children and youth have had, what their reactions to that are, so how their coping mechanisms and what the impact of it, and then as well as their protective factors. So where do they find sources of support? We developed a referral and response protocol, which is really, it's not necessarily chronological order, but here's all the things that you need to think about when you are making a referral. How do you have those conversations that I was discussing earlier about these are the best options? What are the options for you? What are the things? How do you have conversations with them about the pros and cons of signing a statement that says you can see all their records, you know? And then a family engagement guide, which really is just kind of the basics on how do you truly engage families in decision. Informed agency self-assessment, which is something that agencies can use to kind of see where they are on the, on the spectrum of trauma-informed and healing-centered policy and practice within their group, within their agency or organization. And then we also have a grant application development menu for funders, which is still need to come up with a new name for that. But that's really for folks at the state level. What do you put into a request for proposals or a request for applications to better ensure that the folks that you fund are going to be more trauma informed in the work that they do? And so for all of these, except for most of these, we have e-learning courses, which are linked to either within the description or up here where it says training on the website. So we have e-learning courses for how to do community resource mapping. We have a course on what does it look like to do trauma-informed screening, no matter which tool you use, and then a training on our particular screening tool. Then we have a training on the referral and response protocol, which is kind of choose your own adventure in that one. And also a training, actually, those are all of them, but upcoming, we're going to have a little video on how to use the assessment and move forward in the process of becoming a more healing centered organization. So that's, stay tuned for that.
So, how many do you have any data on, like how many communities or organizations are accessing these tools? And then, and I know that this is a really heavy lift, but any sort of outcome data, even process outcome data that you've received around this?
So we have tried many ways and means of collecting information of, you can do, we get like how many people have accessed a course and a training and that sort of thing. So we can get some solid numbers on that, which are, maybe 400 for the screening tool or 300 for this, and then you can do website hits, but we have actually tried to do surveys out in community, but it's the one challenge, or the biggest challenge of it being cross systems, is like, how do we get to people who have, how do we find out that information? We don't know what we don't know. But I will say system-wide, the best data that we have gotten is from Department of Juvenile Justice, because they did implement the screening tool system-wide and statewide. So it was a process of about 3 years that we changed their policy to incorporate this. We trained everyone, and we have, they've screened thousands of kids, because essentially any youth who gets a social history conducted gets a screening done, and that's part of their social history. So, pardon me. We have learned from them, and we do have a follow-up group, a couple of things. One is, we have the data on the screen, but two of the big data pieces were that the most commonly, and this, we also have a few social services departments who we know have implemented it. And across the board, most common form of victimization related trauma. I will say our screening tool is limited to like victimization related trauma. So it's not, unfortunate, doesn't cover everything, but community violence, weapon exposure are the two top. These are things that, in addition to that, about a fourth of the kids that we have in our database and in the DJJ, Juvenile Justice Database, have had thoughts of threat to harm herself or others. And that's across the board. I thought maybe it would be higher. The interesting part is that prior to DJJ implementing this screening tool, they were using the Adverse Childhood Experiences Questionnaire, which is a questionnaire that's designed for adults to find out, to see the links between trauma, adverse childhood experiences, and health impact. They were using that questionnaire, and that there were no questions about community violence or weapon exposure or threats of harm to self or others. So just anecdotally, both in piloting it and in conversation since then, particularly around like the threats of harm to self or other, they said, this is something we would have never known. And we made a totally different referral based on that. And what if we hadn't known? So that's been pretty impactful. Also at the statewide level, and in terms of outcomes data, because it's really hard to link whether it's, the tool, we're hopeful for some. They have through different state level grants like the Thriving Family Safer Children grant, those folks are implementing pieces and parts of the toolkit. So we learn about things like community resource mapping that folks do, and how many resources they discovered. So unfortunately, we don't have a lot of, at this point, outcomes data, but we're definitely making every effort, and hoping that at some point we will have more of that over time.
So with regard to kind of the outcomes of identifying the victimization issues, can you talk to us about kind of any feedback you've received about why? Like, great, you've identified it. Now what? How is this helping the people in the field? How is it helping people who have been traumatized?
So interestingly, this is something that we are literally have been looking at DJJ, because that is, even though we piloted the screening tool across systems to make sure it worked, and it did, in that everyone said it did what it was supposed to do. So it was reliable, but at first we were using words like validity and like validity. You need to have a particular system doing it in a really controlled way in order to look at that. And so it is a reliable tool, research, evidence-driven and informed. But at DJJ, what we have looked at is trying to figure out, okay, those very questions. Initially, we had these very broad categories of collecting information about what happened next? No referrals, or interventions were needed. Were they internal or external? And then what are, were there educational information given, that kind of thing. What we learned, and what we are in the process literally as we speak of changing, because we decided we were going to wait for like a full year of data to come in and then go back out and talk to folks and reconvene the work group that met for so long. And we are adding new categories to better capture that information. So for example, if they said no interventions were needed, is that because they were already in services? Is that because they truly weren't needed? Was it no new interventions? And then with the referrals, we're trying to drill down like where they made the referrals, but knowing that it differs by community, but was it to a community services board, or was it to, a private counselor, or, whatever it might be. So we will have more data on that soon, because that is something that we, again, creating it across systems make referrals to all different kinds of folks. So now that there is that particular system, we can drill down a little further, knowing where they generally make referrals to.
So, as you know, FACTS focus is very broadly based, is on family violence prevention and treatment, which we have kind of the broadest perspective of the prevention spectrum, and the issue of family violence is across a lifespan. But I'm wondering if, you talked a little bit about the DJJ screening and identifying community violence. And this is totally, you might not know these numbers. Do you have any recollection or any kind of sense of around the prevalency around issues of family violence, either exposure to domestic violence in the home from that population or abuse themselves?
We know, so there is a question, and if you give me a second, I can find that answer for you. I can find, at least with the DJJ, that answer. And so give me 1 minute, because I can find this one.
Yeah, because I know, like, nationally, and I know you know this too, but nationally it's, really high rates of exposure to those issues. Often, those are the kids that end up in these systems, or the kids that have been exposed to that specific type of violence in the early years. I mean, that from years of national data. So I'm just wondering if that was consistent with kind of the national data around that.
So we have, there is a question basically for each yes answer they give. So yes, they were, had seen a firearm or another weapon that was threatening to them. They'd experienced physical violence. And if they said yes, then we asked, was it a family member or caregiver? And that's really mandatory reporting piece of it, because these are all mandatory reporters. And how long ago it happened. Those are both to kind of assess risk. Was it 30 days or less? For family member perpetration, so this was for the first full year of data, which was through, July 1, 2022 to June 30th, 2023. There were 2,335 screens completed. And of those, 26% said they were perpetrated by a family member. Now, knowing this, that's the report rate, as you, I'm sure, well know that. Now we do, in the DJJ setting, we do, as part of the training, we encourage, because there's always the question, well, the parent or caregiver can be present during the screening tool. And like, what about the kid? There's always that question, but it's their right to be there. And so we can't say, no, you can't be there. But we do encourage the workers, if it's possible, to do the screening with the youth, not in the presence of the parent, because we just think they'll get better information.
And just one last question in that, are there any questions, and there may very well not be, just because of the sensitivity of the issue, around sexual abuse?
There are actually 3 questions. And so
Okay.
what the questions kind of start at I don't know how you say it, they go from, they're all serious. I don't want to use that terminology, but the more personal as you go on. And so the last 3 questions are about, there could be an indication of trafficking, because it talks about an exchanging money or goods for, sexual acts. And it talks about pornography, whether they'd had any pictures or videos taken of them. And whether anyone had ever exposed themselves. Is pretty much, those are the last 3 questions. So those sexual items, we had about 13.3% that answered yes to those. Again, that's kind of one of the things that we say, of like, when people ask about rescreening, and we say, it's not necessary. We know with domestic violence, I know that I can tell you, because you have the background too. we recommend this is not something that you need to just do one time, because chances are you could screen them one time, two times, and the third time, they give you a different answer. So that's not to say that's reflective of the occurrence of it or the prevalence of it. It's just what they reported.
Right. And I would think that the variable of the parent in the room is also a big
Hmm.
thing around those issues.
Yeah. And we
So
do
it's
have, I mean, occasionally we'll hear like it'll be like the youth is the one who wants grandma in the room. Occasionally we'll hear
oh
that.
yeah.
Most of the
Yeah.
time not, but occasionally that's what we'll hear.
Yeah. Yeah, and it kind of is what it is. So it's a snapshot, and
Yeah.
it's it's kind of the tip of the iceberg probably around a lot of these issues, but um, it's at least getting into that, kind of pushing towards that transparency and kind of openness around some of these topics, which we know is critical. So tell us about the Vicarious Trauma Focus Group project, the new project. I keep saying new,
Mm.
but but everything's kind
Listen,
of new. I think within the last 5 years is kind of new in government. Um, so tell us about that project and what you're seeing, what you've seen, and what next steps are.
so we actually have two parts to we wrapped up this. There was focus groups, and then there was the survey. So we did focus groups, 20 focus groups. They were virtually held for accessibility with local family services and benefits workers and supervisors, as well as regional practice consultants working in family services or supervisors. And we asked them about their experiences of vicarious trauma, to try and get some idea like how common it is. We wanted the quantitative and qualitative data. What their sources of support in their agency were around that, and whether there were official formal programs and what their informal sources of support were, and what kinds of things they would like to see happen. Obviously, I'm a big fan of focus group data. It's very rich. It's very rich data. But I will just, because we do have a report, the focus group report the survey report is coming at the end of this week, and then we're going to be releasing all of that. And I'll send this to you afterwards. It's going to be like our listserv for folks. But I can send these documents to you. We've got a focus group report that's already done, and then that we had our research and planning folks analyze that data. And then we've got the survey data, which just came out. But essentially, and I'll give you a quick couple of slides on the survey, because I think that just two of these, because it will give you an idea of just, people like to have hard data, I know, but we'll just say they both said the same thing, just the focus groups had a lot more stories to them. Although people did not hesitate in the survey to do the open-ended questions. So we got quite a bit from that. Okay, so I'll just do, so in our survey, we had, again, the same study population, except for we did include the hotline workers as well. We had 947 respondents, and there's just some demographic data there. But so in terms of formal procedures or strategies in place, the vast majority were HR benefits, and that essentially is EAP. Um, and then you see that they kind of taper off from there.
Say,
But
I'm
if you look,
sorry. Say what EAP is, Lori.
oh, sorry, Employee Assistance Program, which in most cases is free, a number of free counseling sessions that's offered as a benefit from insurance. And I think it's typically usually 4 sessions. But you'll see that was the most common, and everything else, it's pretty much 35% or less in terms of their formal procedures or strategies in place. And, we asked even about dedicated space or tools to decompress, just 23%. Any debriefing of incidents, 13% peer support program, and that would be things like a warm line or support groups, 13%. You'll see a counselor, less than 1% said they had any kind of on-site counselor. And then effectiveness of strategies. So only 0.02% said these were extremely effective. 28% said moderately and 28% said slightly. So obviously there's plenty of room for improvement there. And I will just skip ahead because we also had a student for the entire year, school academic year, do a capstone on vicarious trauma in the workplace, which looked not only at this data, but also at different states and models and costs, and did a thorough lit review. And essentially, so here's the problem statement: that too few social services workers receive support. And the purpose of the report was to make recommendations. And they looked at 3 alternatives, which was the peer support model, which is the warm line, helpline that's usually staffed with retired employees. The community resilience model, which is a training-based model that teaches folks about how to see signs of stress, adversity, or trauma. And then what a lot of us know from kind of critical incidents, it's kind of more of a law enforcement model, critical incident stress debriefing, that used to be very popular, where folks would come together, facilitated by a licensed clinician, to talk about their common experience with trauma. And overall, the recommendation was that a phased approach of the community resiliency model and the peer support model. So what essentially was the recommendation was that we first go out and kind of do these education sessions where we that are template or a train the trainer model and the community resiliency model, and where we have people be able to recognize when they are experiencing trauma, recognize the signs of kind of those symptoms, and then once they learn kind of to know when that's happening, then they would know that they should probably call for support with the peer support line. Was pretty much the the recommendation around that. And that's, of course, in a perfect world, that's not to say all of those things can happen, or they're, funding and that sort of thing, but that was the recommendation. So all of this is going to be in a package, hopefully by beginning of next week. And we'll be sharing that out with folks. But we really we kind of knew what we were going to find, or we had a good hypothesis, we'll say. We kind of, and the focus groups were really, and anyone that report it's pretty powerful to hear the stuff and the things that people go through. And, we know that we have about a 44% turnover rate for folks like in their first year of service in family services, which, it's just because they see a lot of really hard things, and essentially there's not the amount of support that they need, particularly when you're talking about new workers, maybe just got out of college, and then they go and they have this serious injury they go to see, or they have a child fatality. And then, as you saw from those support models, there's not a lot of formal support programs in place, and then they don't know what to do with that. And so that's kind of going to be our big focus for the coming year, now that we've done the research, is trying to figure out how we can implement a program.
And I'm sure that I know the answer to this, but will these reports be shared with like the League of Social Services?
Oh,
so
absolutely.
the directors of all the agencies can have access to this data too.
Yes. Yes.
And before we jump into just one more thing, I wanted to just touch with you is the issue of the training academy, which we thought was maybe off the table. Now it seems like it's on the table. And
Yay.
what role, if any, tell us if you can kind of share a little bit about what you know about that, and what role, if you see your group playing, if any, in that. I know this is like hasn't even started yet, but it's a really exciting opportunity, I think, that relates to a lot of the work that you're doing.
Mhm. So the training academy is what we say is a very trauma-informed model. So this is basically training academy is for local workers, benefits and family services. Benefits, the benefits piece is really new because they didn't really get this kind of training before. It was all very transactional, the training that was given to them. Now they're actually like, they're seeing a lot of the same people, a lot of the same people who come in for family services go in for benefits and apply for benefits and have support that way. But this is a place where new workers will come with a cohort, of people who are new workers from around the state, and they'll come in and they'll go through these courses that are, as of now, there's lots of required courses, but they get sign up for this course is offered this date and this course is offered this date. They may or may not be with the same people, but probably not. But this is what's so great about this is two things. One is that it's consistently applied information, every more of a tracking better that people are getting the training. Second is that they have this peer support built in. So if they go through this academy with their colleagues, then they automatically, because we heard particularly in the focus groups, they were like, those informal sources of support were like their colleagues and people they could talk to at work. And so I think having somebody who's in that same kind of time frame as them that they can reach out to and build relationships with is just going to really be a big help. And in terms of our office, I will say that that is someone's shop to do. There's a division for local training and development. However, we work very closely with Patrick Bridge, who's the director, and his team on that. And in fact, just my one of our policy specialists, Stacy, and I both were asked and they had a summit of all of their training folks from throughout the state come together to a summit, and we actually spent a day with them and facilitated some group discussion around what does employee well-being look like? What are some practices that we can put into place? And they have always been very like, hey, take a look at this training, see if this, can you review this and make any suggestions? And we actually do the same, with them. So we foresee that some of this training piece will be incorporated into that. The training around trauma will be incorporated into that academy. And even now, we are learning, this foundational trauma e-learning course that we developed, which is for anybody who's in the Commonwealth of Virginia Learning Center. Unfortunately, it's not like general public, but anybody who has an account is like a 45-minute course on foundational trauma, because we found a lot of times we jump ahead. We're like, oh, what does trauma-informed policy look like? Or what is a trauma-informed organization? And folks don't have that basic like foundational knowledge of what trauma is, which is kind of what we were talking about earlier in a very quick couple of sentences. But and we're, asking them, hey, share it out with all of your local people, because they get a lot of, trauma-informed supervision, different as it relates to other things, and they've got great training. But a lot of, we're all sharing and working and collaborating with each other. And I'm super excited about the academy.
Yeah, that's great. I mean, I think it's important that people who are outside of this work know that there's 120 different local departments of social services, and Virginia is a state that is locally, what is it? It's locally
State
administered, but
supervised,
state
locally administered.
supervised, right? Even though that's kind of flipped in reality. So you oftentimes have kind of a huge variation from locality to locality in how workers in capacities around local departments of social services. So this academy is a way to kind of centralize a lot of that kind of information that's going out. And I think it could be really, hopefully, I think very helpful and transformative in a very positive way for all of the local departments. And we are down to 3 minutes, but I can't let you go without talking about the Science of Hope framework
Yeah.
and what's
And I
happening at social services.
And I realized I forgot that with the big projects that we're working on, that's like really, and lately it's been a bunch of times. So very short story, and anybody, there's a great TED talk on if you want the introduction, but the science of hope is really a framework based on science that kind of there is research, a lot of strong evidence to show that people with higher hope experience lower burnout, lower there's lower rates of turnover, there's higher engagement, and that's in the workplace at least. But essentially, the science of hope is a framework that's built on one really easy tenet, is that you have a goal and then you have pathways to get there, and that you have willpower. So it's the goal, the pathways, and the willpower. And so what the framework kind of promotes is finding a pathway, because that's what happens a lot of times. So if you have a goal and you have the willpower, the mental energy, but you don't have the way of getting there, then it's a wish. And so that's a lot of times we use the term interchangeably, but it's not. And so what we're doing is working with some national experts around this, Dr. Chan Hellman and Angela Ferris, on implementing this framework at VDSS at the state level with state employees across divisions. So what we're doing during the first year, which was, we just started this, we have what we call navigators. It's a certification 12-hour training where you have folks who are trained essentially as coaches to help identify pathways. That's kind of the main, and to learn strategies for sustaining willpower and mental energy. And we just did a navigator training, got 19 more week before last. And essentially, these are folks that what we're trying to do is take, our first year was really focused on awareness of what the framework is. And now we're really looking at how do we integrate this framework into the work that we do, and how we communicate with each other, how we communicate to the public. So just a super quick example would be, this is when you go into a building, and you see it's, whether it's a child support office or a something at the DMV or whatever it might be, and it's the sign says, here's all the reasons that you won't receive these services. Don't, you need this, this, and this, and if you don't have this, then you won't. So you're automatically, you are depleted. You're like, there's no pathway there. There's not. They're depleting your willpower. And so maybe then you're communicating things that are like, here's how you can get there. You can get there from here. So it really is that the future can be better, and that you have the power to make it so. And it's just by taking those actionable steps. And there's a ton more information about that, but we are just really getting started. But if folks look into it, Oklahoma Department of Human Services implemented it and saw significant changes, increases in retention and engagement. And then they implemented across all state agencies, and now they're actually doing it at their administration, their governor's office level. And there's a ton of data out there to support it. So be on the lookout or listen out for more.
Well, thank you, Lori. And we're going to post this discussion on our website, and we'll also post Dr. Hellman's TED Talk.
Yeah. Yes.
Because I think that's always good. And it's like 20 minutes, and he does a great job of kind of doing a high-level overview of this work. And I was fortunate enough to get to go through the training.
Mm-hmm.
And so I'm a little bit familiar with it. I'm really going to be interested to watch and see how it begins to kind of be implemented throughout DSS and hopefully catch on. So, well, thank you so much for your time.
Thank you for inviting me. And I guess we didn't have a hard time taking up the full hour. So
we did not. No, there's lots going on. And I think, I've known you for a number of years, and I was just thinking, like, I think you found like just the perfect spot for your background and passions, because you're clearly like so excited about this work, which is exactly what we need people in positions to be, is really passionate. So I thank you for your time and all your work, and I look forward to working with you on some of this stuff in the future.
Thank you so much, and we will talk soon. Thanks, everyone.
All right. Okay. Take care.
Bye.